Hello, I'm Beth Britton, MBE. I support Dementia Community with their communications work. Welcome and thank you for joining us for today's webinar, Why We Must Improve Access to Dementia Assessment and Diagnosis. Before I introduce you to our presenter, I wanted to briefly explain a little more about Dementia Community. Dementia Community is a charitable community benefit society, a membership cooperative that provides learning and networking opportunities for the dementia care community. We are an independent voice and inclusive organisation aiming to help all of our members to feel connected, informed, inspired, empowered, purposeful and engaged in co-produced changes that improve everyone's experiences of dementia, both in care and in wider society. This webinar is just one example of the many ways in which we do this. Community members own a £1 community share in Dementia Community, and membership is open to everyone. So if you aren't already a member, do join us. You can use the QR code on your screen or the link in the chat to visit our membership page. If you're having any difficulties in joining Dementia Community, please do message me and I will try to help. I also have some notices to share with you before we begin the webinar. So, firstly, our call for presentations for the 20th UK Dementia Congress is now open. Proposals for presentations are welcomed on all aspects of dementia care in all settings and from all diverse perspectives of everyone involved, including people living with dementia, care partners and family carers, health and social care practitioners and professionals, people working in the housing field, the voluntary, community and social enterprise sectors, researchers, innovators and entrepreneurs. So pretty much everybody, hopefully, who's on this call today. Do use the QR code on your screen or the link in the chat to find out more. Please note that the submission deadline for presentations is the 1st of June 2026. Secondly, and still relating to the 20th UK Dementia Congress, which this year is being held at Doncaster Racecourse, early bird tickets are now available. If you are a Dementia Community member, you will enjoy a 10% discount on the early bird rate. Do use the QR code on the screen or the link in the chat to secure your single day or 2-day ticket for Tuesday the 17th of November and or Wednesday the 18th of November 2026. Please note that the early bird tickets end on the 31st of August 2026. And then finally, a thank you to the Unforgettable Foundation, who have kindly set up a GoFundMe page for Dementia Community's webinar programme. Our webinars are free to attend and we want to keep them this way to ensure access for all, but providing them does have cost implications for Dementia Community. This fundraiser is intended to help meet those costs, and if you'd like to donate, please use the QR code on your screen or the link in the chat. Thank you. Now, before we begin the presentation, a little bit of housekeeping for you. You should already have been alerted by Zoom that we are recording this webinar. Please use the chat for your questions. We will have a Q&A and discussion after the presentation, and we'll be keeping an eye on the chat. And afterwards, the recording of the webinar will go onto our YouTube channel, Dementia Community. So let's get started. Our presenter for today is Dr. Zena Aldridge, who is an independent nurse consultant. Zena wears many other hats as well, so that's certainly not all of them, but that's the one we're sharing today. So Zena, it's lovely to have you with us. I really appreciate your time and expertise today, and over to you.
Thanks so much. And I'm really, really pleased to be here. And thank you for the opportunity. So let me just get my slides up for you and hopefully we should be able to start. So you'll be aware of the title for today. So it's about improving access and timely assessments, really to get an accurate diagnosis for families affected by dementia, recognising that dementia impacts not just only on the person living with it, but all those around them. So for the overview, just to give you a kind of a sense of where we're heading with this, is really just to kind of challenge some of the myths and misconceptions associated with a diagnosis and the assessment process. It's why we really need to make sure that that accurate diagnosis is enabled at any stage of the condition. Whilst we absolutely would like to see people accessing a timely and early diagnosis, we know that doesn't happen for everyone. And so it's really important that people at any stage are able to access that diagnosis should they choose. It's also important to recognise how that assessment might not only recognise dementia, but also whether there are underlying treatable conditions. So, really challenging those misconceptions that certain symptoms are definitely going to be dementia. Sometimes these symptoms are really nebulous and difficult to ascertain. So, it's really important that we get a proper assessment rather than kind of make assumptions. And actually thinking about even that diagnosis in the advanced stage of dementia, how that can be really important in supporting families, the person living with the condition, but also those caring for them in decision making and care planning, particularly if someone might be approaching the end of their life. So the question's always, well, why is this important? Unfortunately, or fortunately, whichever side of the fence you sit on, the Prime Minister's challenge several years ago set a diagnosis rate of 67% as a target. Now, the difficulty when you set a target is people start to get very fixated on a number rather than the underlying benefits of that diagnosis for those affected. So, each GP practice was trying to reach the 67% of the predicted amount of people. But actually, we need to really dig in as to why it's really important. Why is that diagnosis important? And often what happens is when we think about accessing support and information and being able to live well with dementia, knowing the condition that someone has can enable them to get onto that dementia pathway. So you may not be familiar with this slide. This is the NHS England transformational framework, the Well Pathway for Dementia, which is nearly, I think, 10 years old now. So this is not new news. But the idea is thinking about how we see dementia across our systems and how we enable people to access the services as they need them throughout the course of their condition. But of course, if you don't have that diagnosis, sometimes those services aren't available to you because the diagnosis is required to meet a threshold or get into it. And so, again, it becomes really important for people to understand what their needs are and what services are available for them. So that diagnosis can help from that perspective. And it's seen as after preventing well, which is obviously something we really want to focus on, is actually that diagnosing well is almost that first step when someone has got symptoms of moving through that supporting living and dying well with the condition. So when we think about the numbers and where we're still looking at inequalities and the number of people that perhaps don't have a diagnosis, we see there that in England there are around 900,000 people who are expected to be or estimated to be living with dementia. That for the whole of the UK, that figure's around 1 million. And we know that around 1 in 11 people over the age of 65 are living with dementia. So yes, we recognise that it's a condition mainly affecting older people, but of course we need to remember that there are around 70,000 people living with young onset dementia. So those people who experience symptoms before the age of 65. Dementia remains the leading cause of death in England and Wales. And I think that's really important because dementia is a long-term palliative condition that requires support throughout its progression and the disease journey. So without knowing at what point someone is and what their symptoms might be and what disease is underpinning it, it can be really difficult to plan for that. But then we start to look at how many people have a formal diagnosis of dementia. So despite the fact that we suspect there's around 900,000 people living with dementia in the UK, the number of people who had a formal diagnosis, and that's a formal diagnosis where they've actually had an assessment and it's been recorded appropriately on their GP record, is only around 500,000. So you can start to see where we've got this inequality in the amount of people who may be living with the condition. It may not have been recorded appropriately or it may not have been assessed appropriately. So again, these barriers start to exist. And there are multiple benefits to having an appropriate diagnosis. And I will keep saying appropriate because all too often I've seen Chinese whispers in people's records. So, for example, an older person might go into hospital, they might present in a certain way, they might appear confused, or they might not feel they may look quite frail, and people make assumptions based on the way that they present. And I've seen people have query dementia written in their notes, and by the time it comes out of hospital, it says that they have dementia, but they've never had an appropriate assessment. Of course, there will be people who are in hospital who do have an appropriate assessment, so we're not saying this is a carte blanche approach, but it's really important to make sure that they have had that appropriate diagnosis, assessment, and an appropriate formulation of their diagnosis. Because actually, when people are aware of their diagnosis, it gives them the ability to plan and make decisions about the future. If you know that you have a condition that is progressive, it enables you to think about how do you want to prioritize your decisions about what you might to achieve in your lifestyle, but also what you might want in the future, at a point when you still have the ability to communicate and have the mental capacity to do that. And that can be really helpful for families as well, because all too often families are left making decisions at a point where they've not had these conversations, and it's really difficult to know what the person themselves might have wanted. It gives us an improved ability to gain access to treatment options and symptom control, not only for the symptoms of dementia, but also some of those comorbid conditions that people might be living with. There are very few people who only live with dementia. Most people with dementia, particularly those who are older, have what we call comorbid conditions. So things like diabetes, heart conditions, painful conditions, depression, a whole plethora, and actually they can interact. So if we know that someone has dementia, we can think about how to treat not only the dementia, but those accompanying conditions more effectively. It enables people to access specialist support and information and advice, not only the person themselves, but their families, those who care for them, and also the professionals that care for them. If professionals know, they know how to better support people. We've already talked about the comorbid conditions, but also thinking about that advanced and anticipatory care planning. I have an advanced care plan. I don't have a long-term condition, or I don't have cognitive impairment or dementia myself, but my mum had motor neurone disease. So I find it really important to be able to have those conversations at a time where, these things may happen to me. I don't know. I have to say I'm a real advocate for everyone having an advanced care plan, because none of us know on any given day what the future might hold. And whilst we might not choose to have those conversations, if you wish to have those conversations and have that choice and care planning documented and known by those around you, that can be really empowering, and something you can then put aside because you know that's the job that's being done. If you have the diagnosis, it would be on your GP record if it's recorded appropriately, and that would enable people to access an annual dementia review. Now, again, I could critique the value of the reviews and the caliber of them. They vary considerably, but it's really important that there is access to those reviews in a timely way, and they are evolving all the time. Again, understanding symptoms, how to manage them, really important, but also thinking about how we can improve the health outcomes for not only ourselves, but for the people who are affected and their families. If we know some of the difficulties that we might face, we can plan ahead, we can think ahead. All too often, people end up in a situation where they reach crisis point, and we're reacting in a crisis rather than being really proactive and planning some of the things that might happen and how we can reduce those crises and the distress that they cause. If we are involved with multiple services, if we have lots of conditions, lots of people involved in our care, if it's known, there's a shared understanding across those services. And we're really very bad in our systems at looking at singular diseases or problems. If you've got heart failure, see a heart failure specialist nurse or a community matron. If you have dementia, you might see a dementia specialist nurse. But if we have as much shared information across our systems, it helps people understand us as an individual. It also helps us understand what we need in terms of the skill mix and the learning and development of the staff who support people living with dementia in whatever area that might be, whether that be in the health service, in social care, in the voluntary sector. But if we don't know how big the problem is, how do we know how to equip the workforce and enable them to have the support that they need, but also for us to have the skill mix that we need to make the outcomes better for those living with condition. In some ways, sometimes it can help with access to a financial support. And actually, one of the things that I'm always very keen of as a clinical academic is the ability to participate in research. A lot of people who are diagnosed with dementia really want to get involved in research that they can help others. And I've certainly had conversations with people who find it really important to be offered that opportunity. So they see that part of their ability to take control and make a difference later on. But what we have to remember is there is a huge amount of myths and misconceptions, and these are kind of the big ones. There are lots, but actually, it's kind of really challenging these misconceptions. I still hear that it's a normal part of aging. Dementia is not a normal part of aging. It is a syndrome created by neurodegenerative diseases that have a diagnostic process and have a progression, and they behave in different ways. Different diseases have different symptoms and different progression. And so dementia is not a normal part of aging. We'll come back to that. We've already talked about the fact that younger people are affected by dementia, although not in such high numbers. It is not only a condition of older people, but there's still this misconception that that is the case. I still hear from people living with the condition, their families, and professionals. So nothing can be done. So what's the point of having a diagnosis? Whilst we don't have curative treatments, we have lots of understanding about how to support people more effectively when they're living with the condition and how to enable them to live well and have a good quality of life. So there is lots that can be done, and lots of adaptations and lots of information and knowledge that people can develop that can help them make decisions and choices that enable them to live the best life possible. I still hear it's just memory loss. Dementia is not just memory loss. Yes, as we age, we may experience some memory loss associated with aging or other conditions, but memory loss alone is not dementia. Memory loss has to be accompanied with by another cognitive deficit, and we'll come back to that. The other thing is people are frightened. They might start to have problems with their memory or their cognition, so they just assume it's dementia and they're frightened by that and don't want to go and have an assessment. So, you know, that I'm having problems with my memory, so I must have dementia. That's not always the case. There's lots of underlying conditions that may well be causing that memory problem as well. And also there's this fear that once people get their diagnosis, that people will start to take their autonomy and choice away from them. But the earlier people get that diagnosis, the more autonomy and choice they have. So I'm a huge advocate in kind of challenging these misconceptions that we'll kind of go through. Equally, people don't know where to seek help. There are lots of fragmented pathways that exist. People don't know, what to say, how to go to the GP, raise these questions. It may well be that the person themselves who's having some of these issues doesn't recognize them, and it's the family that recognize them. And there may need to be quite a lot of negotiation with the individual to seek help and advice from a health professional. I have to say, there's still a lot of misunderstanding by health and social care professionals. Not all of them are experienced in dementia care. We do have to remember that general practitioners, for example, those who work in general practice, look after people with such a broad range of conditions. They're expected to know a lot or a little about a lot of things. And so this might be something they're not particularly familiar with. So it may well be that as other specialists in the condition or as empowered people living with the condition, we help to support those conversations. I've already mentioned that we do tend to look at singular diseases or problems, which means that actually someone could go for an appointment, for example, about diabetes. They may be experiencing problems, but the focus of that assessment might be about a diabetes checkup, for example. And I think that doesn't enable us to kind of open up conversations more broadly about what else might be going on for that individual. So it's really important that we start to join the dots across our healthcare systems. Whilst I said the diagnosis can help with communication, we also have to recognise that communication isn't always positive or useful. And often when we're using different digital systems, they don't always communicate. But things are certainly getting better. The digital shared care record is starting to make a difference in that space. But, we have to recognise that some of the enablers are also barriers in some ways. There's also this misattribution of symptoms. So, for example, people might have other conditions, and where they start to show symptoms, people might think that's associated with something else, and may not see that there is something else ongoing. And we're really good at that. Once people have a label, we tend to focus and put everything that changes to that label, whether that be a label of dementia or some other condition. So it's really important to know what's normal for the person and what any changes might mean to that individual. Of course, fear and stigma, and that can be from a personal level, it can be from a cultural level, a societal level, may impact on someone's ability or desire to go and get a dementia diagnosis or assessment. Again, there may be a lack of appropriate resources, skills, and knowledge to enable people to get onto that assessment pathway. And of course, we've heard a lot over the last couple of years where people are struggling to get appointments with their GPs. But actually, on the whole, that is improving now, and people are getting those appointments that they need to get the foot through the door. So we're going to just scoot through that one. So if we don't enable people, we've talked about what the benefits are. So these are some of the deficits if we don't get that opportunity to get an assessment. So thinking about those missed opportunities to identify reversible symptoms. Now, if someone presents in a GP practice with concerns, it's not automatically assumed they have dementia. There are lots of things that we have to filter out before we actually refer someone to a specialist service for further assessment. So, for example, if we were to present or if we don't present in a GP practice, someone doesn't present in a GP practice, it could mean that they have underlying treatable conditions that are not picked up. So depression, for example, a lot of older people and people of a working age live with depression, and some of those symptoms might be very, very similar. Depression is treatable, but if you don't present with the symptoms that you suspect might be dementia, that might not be filtered out. There might be other medical conditions that are causing some of the symptoms. So once you present, people would be screening for things like depression and anxiety. There will be some cognitive testing that will kind of test our memory and our cognitive functioning to see how it's working. And actually, sometimes, although we might think that there's a lapse in cognition, the tests will actually say, you know what? You're fine. Actually, you may think that you're not as sharp cognitively as you were, but actually it might be because there's a lot going on, or you haven't been well, whatever. And the person will have blood tests as well. So again, if there's any medical underlying causes, and if there are any discrepancies there, they will be looking at treating those before they put someone through a dementia assessment. And this is why I say it's really important to get that proper assessment and process going, because otherwise we could make those false assumptions when there is something that's treatable. Of course, then there's the lack of access to treatment options, the lack of understanding, the inability to plan for the future, and that poor management of comorbid conditions. Some of the things like chronic obstructive pulmonary disease or diabetes might require lots of complicated medication regimes that might be difficult for someone with dementia if we don't know that they have the condition. Whereas if we do, we can adjust those treatment regimes. So again, that can impact positively on those other conditions that they're living with. Oh, my mouse has disappeared. So I'm just going to give you a bit of an example. So this James, not his real name and not his real photo, was a gentleman that I'd been working with for quite some time. And his family felt that he might have dementia. He didn't want to go and get the assessment. He was really frightened that it would really impact negatively on the way that people saw him and how he perceived himself. And the more I got to know James, the more we started to kind of gradually unpick his concerns. And to me, he didn't appear to be someone who was experiencing dementia. I actually felt that there was something else that was going on. So through time, I gently encouraged James to have his hearing tested. He'd never had his hearing tested. And it turned out that he was incredibly hard of hearing, which had happened over several years. He was also quite depressed. And actually, we were able to look at some of the triggers that were attributing to that. But there was what we call some mild cognitive impairment that was present. So he had some changes. He had a scan, and this happened over a period of time. We really had to build some trust and acknowledgement. And he then stayed on a program where because he had mild cognitive impairment, he was reviewed 6 to 9 months later to see whether he actually had any deterioration in his cognitive function. He didn't. And so for him, it was kind of life changing, because where he'd convinced himself that he'd got dementia, he hadn't. He'd got hearing loss, he'd got depression, he'd got some cognitive changes, but they were associated with his depression and not with a diagnosis of depression. Diagnosis of dementia. But again, what he did say as part of that process was he wouldn't be frightened to come back again if he had further concerns, if there were changes, because what he thought might happen and what actually happened, and the way that he was enabled to go through this process and people make assumptions and see him as an individual, really made him feel that it was a process worth innate. And it gave him some positivity in the fact that actually he wasn't just going to be written off. So when we talk about dementia, I'm just put this slide up because ultimately, I'm sure most of you know on this call that, you know, we have these main types of dementia, and dementia is the umbrella term. And this is, again, really important why the diagnosis and assessment is valuable, because each of those conditions presents in different ways with different symptoms and will affect the person differently. I get really frustrated when it says in someone's notes, this person's living with dementia, but it doesn't tell me what type of dementia. If we had an infection, for example, we wouldn't accept that the note said this person has an infection. We'd want to know what sort of infection they had, how it was affecting them, and the best treatment options. So we absolutely need to make sure that we try and get this for people living with dementia as well, because if we understand the type of dementia they're living with, then we can actually help support them more effectively. And as I said, memory loss alone is not dementia. It's got to be associated with other cognitive challenges. So it might be changes in language or understanding. And there is a reason why we ask people to complete a COP face on an assessment tool, on a mini cognitive assessment framework, because actually that can be a real indicator that someone is having trouble with their calculations or ability to draw space between the numbers, etc. So that's not about memory, that's about a different part of the brain function. And so this is why the dementia diagnosis itself shouldn't be seen as a one size fits all. If someone has been told that they have dementia, ask the questions. What type of dementia have they got? Do we know? In the later stages, if someone's diagnosed quite late on, that might be quite difficult and not so important. But particularly for those people who are diagnosed fairly early on, these are really important for questions, because it will enable us to see how the brain might be affected. It will enable us to think about how it might progress, but it's also about understanding that not only the dementia type, but the way that the person behaved and their pre-morbid personality and functioning will impact on how it affects them. It will also affect them differently based on any other conditions they might have. And the important thing is to remember that once you've met one person with dementia, you've only ever met one person with dementia. Dementia is a very, very unique experience to everyone it's affected by. So again, we can't make those assumptions that different particular symptoms are definitely dementia. We really need to have to challenge that and think more broadly. And the other thing I would say is, just as a bit of a warning sign, other conditions can appear to be very, very simple, very similar to dementia. So delirium is one of them, and I'm not going to talk too much about it, but just to really highlight, if someone's developed some very sudden symptoms that are of concern, that, you know, they might be more confused, they might be quite distressed, they might be disorientated, or equally they might be more drowsy and withdrawn. If this happens suddenly, this is not dementia. This could be indicative of a medical emergency. So if you notice those sudden changes in anyone, please do seek emergency support for medical support from your GP or 111, because it could be that this person needs to have urgent assessment and treatment for an underlying cause. So again, people with dementia can get delirium on top of that. So again, if someone's living with dementia and you see some very sudden changes, that's not likely to be a change to the dementia. It's likely that there could be something else going on. So I do like to flag that up, because again, sometimes there is a misconception that these symptoms are always dementia, and it could be something more serious in terms of the need for immediate support and care. And the reason we need to think about all of these things, the assessment of that, is because we are really complex human beings. Dementia is really complex. The way it presents is really complex. We're all very unique human beings. So it's really important that we see each person as an individual and put the pieces together, not make assumptions, and really challenge those myths and misconceptions about what dementia is and what dementia isn't. Because if we don't, what we can do is send people down the wrong pathway. We can make those assumptions, we can label people inappropriately, or they can label themselves inappropriately, having these concerns about the fact they may have dementia, they may not. And actually, sending them around the right pathway to get the right treatment and right support can be life changing. There's been the Alzheimer's Society went out to people living with dementia and their family carers, asking them about their experience of getting a diagnosis and the value of that. And the majority of them felt it was really positive to have the diagnosis. I think a lot of people think it's going to be negative, but again, for those that have gone through that process, they have seen the value in it. So it's really important that we don't dismiss people, that we do listen, that we do screen, and we do think about what might be going on for them at any given time. And listening is really important. I've often seen the case where people have presented and actually people go, oh, you're fine, don't worry, you're absolutely fine. It's normal to get a little bit of this, it's normal to get a bit of that. If you know it's not normal for you or for the person that you care for, whether that be in a professional or personal capacity, pursue it. If that person's been brave enough to go forward and say, I've got concerns about changes in the way that I'm thinking, how I feel, my memory, all of those things combined, it's really important that we don't dismiss that we give them the right opportunity to have a proper assessment in a way that's meaningful. So going back to how can we make this better? So appropriate screening, and doing that a bit more proactively in groups that we know could be high risk. So perhaps people living in care homes who haven't got a diagnosis, for example, people who have conditions that we know are associated with dementia, so that makes them higher risk. But also that improvement of the symptoms, thinking more broadly than just memory loss. So people might be aware of changes to personality or language or their mood, things like that could be indicative of it. Listening to people about their concerns and families' concerns. All too often people get hit, really fixated on the fact, well, I can't talk to you because of confidentiality. Now, they may not be able to share information about that individual, but they can listen to your concerns about that. We certainly need to improve staff understanding and confidence about what dementia is and what it isn't, and enable them to advocate and support people through that process. Actually, sometimes that waiting for diagnosis can be a really challenging time. So again, thinking about how we support people and signposting them to appropriate services that can help them while they are waiting for that assessment. And I think one of the things that I find is really important is seeing dementia not as a label, but ways of advocating for that individual. I had a really lovely phrase last week. No, it was a few weeks ago now, actually, and it was associated to people. They said, jars have labels, people shouldn't have labels. And I think that's absolutely right. So we must move away from the dementia diagnosis being a target or a label. It is about enabling people to get the care and support that they need. So again, if we think about the fact that we are enabling people and really advocating for people to seek a diagnosis, we need to think about what are those differential and intercurrent diagnoses? How can we enable people to be really clear that it may not be dementia, it could be something else, and promote that as a rationale for them seeking advice? Once we've recognised there's a problem, whilst that person might be waiting to be referred on to specialist service for an assessment, and I haven't gone into detail about what that looks like because this is more about us starting that process and getting people into that opportunity to have that assessment. But what do the people need? What do their families need while they're waiting? Whatever their diagnosis is, whether it is dementia or not, there's obviously something that's really challenging for those individuals, and they need support and guidance whilst they are waiting to get that formal assessment and understand what's going on. So do they need support and guidance from a dementia specialist support service or a carer support service? Are they having issues with their social care needs? Do they need support with that? We don't need to wait for a diagnosis to be able to get access to that support, and neither should we, particularly given that sometimes people can wait for quite a long time for that formal assessment. Is there a need to think about reviewing any medication for those of you that work as health and care practitioners? It could well be that some of the medication that a person might be taking may not be helping them and supporting them while they experience some of those challenges. So we might think about that. They could be in a lot of pain, for example. Do we need to have pain relief to support them while they're waiting for other conditions? Or do they need something just resolving in their other health problems that would help them while they're managing this? We don't need to be waiting for one diagnosis to influence what we do about other things. If the person's coming to the end of their life, do we need to think about what care planning needs to happen in that immediate space rather than waiting for a health professional to attribute a diagnosis? These are all really important things, and thinking about how to create personalised care and support plans. And these will be very, very different for everybody concerned. For example, someone in the early stages may want some specialist advice and information and support, where someone further down the line may need more support with their care needs, for example, and looking at sort of those non-pharmacological approaches to meet some of their unmet needs. And when I say it's never too late, at any stage of the trajectory or the journey, pathway, whatever word people like to call it, it's never too late. Even people who are living with advanced symptoms, if they've not had a diagnosis, it can be really, really important to them to be able to get a diagnosis. So we know that 70% of people who live in care homes are likely to have dementia, and many of them haven't had a diagnosis by the time they go into care. And often they may be, again, be quite frail, coming towards the end of their life, or be in the last couple of years of their life. And then it's really important to understand that they could deteriorate, and how do we support them and look after them more effectively. And it can be really important to families as well to understand what's going on, because as someone actually comes to those more advanced stages, they might see changes that they don't understand, but actually that diagnosis might help them understand what's going on and prepare for the future. And I think we wouldn't suggest that we wouldn't talk to anyone else about other conditions such as cancer or things like that. We would be very open and honest about what might happen. It is different with people with advanced dementia. Sometimes because we can't do a blood test and things like that to measure at what stage they are in a way that's attributable to like heart failure and lung disease and things like that. People can be shying away from the conversations. But again, it can be really, really important to understand what's going on for families. And thinking ahead, so there are opportunities where people in care homes, particularly those living with advanced dementia, don't need to be seen in memory assessment services and have scans and lots of cognitive screening, because that wouldn't be in their best interest. But we can look more about their history, speak to family, understand what's been going on over a long period of time to enable us to establish a diagnosis and think what might be happening there. But of course, this needs to be done professionally and in a very person-centered lens. So thinking again about what might be going on for that individual. I'll give you an example of a lady who I met several years ago. She was telling me about her husband who had Lewy body dementia. And she'd not known that he'd got Lewy body dementia till quite late in his pathway. She got quite significant symptoms. She'd been told he'd got Parkinson's. And so she knew he had Parkinson's, and then he started to lose lots of weight and had difficulty with swallowing. And she felt that the services around him were not working effectively. And it was then that he got a diagnosis of Lewy body dementia. And she felt that services weren't listening to her about her concerns about him losing weight and all the rest of it. And whilst he was given some advice through dietetic, he's seen a dietitian, he's seen a speech and language therapist, she felt that actually there was still not the right help and support for her, and that the people had written her husband off. And it was only after his death we were talking, and we talked about what happens to, some people when they experience the advanced stages of Lewy body dementia, and how that can impact. And even sometimes with the best dietetic advice and best speech and language advice, people can lose weight, and that can often be a symptom. And she said, I feel so much more relieved now that I understand that that was a symptom. It, for me, she said, I felt that people writing off about poor care and not meeting his needs effectively. If I knew there was nothing I could do, and actually the most important thing was for me to enable him to have foods he enjoyed safely, and could make meal times part of an experience rather than something that was so stressful, because I was worried about giving him so much food that would was never achievable. That would have made a real big difference to me. So she spent many years actually feeling very guilty, because although he'd got the diagnosis very late, no one had explained to her what that the symptoms of that condition might look like and how that might impact on his health and well-being. So again, just that ability for family carers to understand what they're observing and what they're seeing and what's achievable and not can be really important. Often we, as I said, we might look at the symptoms, we might start to get people on an assessment pathway where they are seen by specialist service for an assessment and potential diagnosis. But it's really important that we do have those wraparound services to enable them to wait for that assessment more readily. And, are there local community groups? Are there any pre-assessment and post-diagnostic support services available that they can get support while they're waiting? And it may be they need some practical help around finances, for example. They may need support with their benefits. They may just need information about what the next step looks like. What does it look like to have an assessment in a specialist dementia or memory assessment service? Because that's often something that people are fearful for. So preparing them for that next stage and thinking about any social care support that they might need. And you see there's some tools there. I think one of the two that I'd really draw your attention to is certainly the Waiting Well document that talks about how do we support people to wait for a diagnosis, because we do know it can take some time, but also why it's important that delivering a dementia diagnosis blueprint of the future also gives you a nice flow chart. So for different people who might have different symptoms at different ages, what might that pathway look like beyond going to the GP and raising the concerns that you might have about living with symptoms that might be indicative of dementia. And I said, I haven't really gone through the whole pathway for this. This is more about why we need to just highlight that actually there are still a very large percentage of people that are living with dementia without a formal diagnosis, and why it's really important that we encourage and support them to get a diagnosis at any time that's suitable for them when they want to. We can't force this on people, but to enable them to get access to the support and care that they may need. Now I'm going to stop sharing my calendar. Absolutely, we'd like to open up for questions and answer, but we're also going to have a little bit of a what would you call it, poll, Beth? No,
Oh,
a
yes.
poll, to kind of think that, I would probably think there's a lot of you on this call that know a lot of this information already, but sometimes we don't get the chance just to sit and reflect and go, actually, yeah, maybe I could use that tool or use that means of communicating slightly differently. So there is a poll now coming up the screen, and Beth, you're much more adept at telling people how to use this than I am.
Yeah, so this is very much anonymous. So I think we were just really interested because Zena's given you lots and lots of information. And thank you so much, Zena, for that. Is actually just, what is the action you're going to take after this? Because you've heard lots of information. And I'm mindful that people will probably be in very different situations. Some people are going to be living with dementia, I know from the chat already. We've got Lynn with us today. You might have a family member, you might be here in a professional capacity, you might be working in a memory clinic. So just really interested in what's the one action that you think you might take after this webinar based on what you've heard. So if you want to have a go at that, I can see lots of people are already. So over 70 people I think have now completed it. And
Yeah,
what
and
we the data.
And
It
it's always
look
really difficult to kind of give you the key information that you might need when you're such a broad audience as this. But certainly, if there's anything that's come up and it doesn't get covered in the Q&A session, and you'd like to reach out to me personally, I'm more than happy that you do that. But hopefully, we can address questions in the next 15 minutes or so as well.
Yeah, and we've got some in the chat already. So from what's coming in on the poll, I would say at the moment the majority of people are going to look at the resources for families and themselves. to try and get some support in that regard. People are going to look at the Waiting Well resources. I don't think these are really well known at the moment, Zena. So it's great that you included them, and they are super important, aren't they? Because people do often have really long waits.
Absolutely. Absolutely. And the referral onto a further assessment doesn't mean to say you stop having problems. There's still issues that are ongoing. There's still anxieties and questions that people want answered through that period. So being able to access that support and guidance while you're waiting can be really, really positive. And you may be accessing other services rather than wait for that diagnosis. So I have seen some really positive interactions in those waiting wells, and people have said what a difference it's made. It's reduced their anxiety. It's enabled them to access resources in a really timely way. So I absolutely would advocate looking at those kind of opportunities and resources where they're available. And if you work in health and care settings and you're not sure what resources there are locally, find out. Have that kind of toolkit that you can offer to families as well, because I think that's really, really important.
Super, thank you. So yeah, I think I've ended the poll, but the top one is people are going to look at resources to support families for myself or signpost those to families that people work with. And also people want to look at the Waiting Well resources with the top two answers. But also we have got some people who are going to speak to a GP. We've got some people who are working in care services where they're actually going to go and have fresh eyes, looking at the people they're supporting. Is there anyone who is potentially needing an assessment to see if they have dementia, or as you've said, many other conditions as well. People are going to upskill themselves around delirium, and I've seen there's been a bit of chat in the chat box about that as well. So amazing, thank you. Do pop your questions in the chat for Zena because we're going to get to those. Before we do, there were some things I just absolutely jumped out at me. I think this subtype diagnosis thing, Zena, this does not happen enough. I work in a lot of
No.
LD services, and it's even more of a lack of it in those services. What can people do? And I know there's a question in the chat about this as well, but the frustration that you can't get that subtype diagnosis.
Absolutely. And I think sometimes it's there. I think what happens is often people's diagnosis is coded really poorly. So it'll just say dementia or what have you. And some of these diagnoses are quite historical, or they've not been conducted in somewhere where they've done the subtype. But I think it's really be curious. If you are a person living with a condition, or a family member, ask, see if that, if there is some evidence further down in the paperwork that would give you a subtype, or actually as practitioners really pushing back and asking for that. And we wouldn't accept this for any other condition. If we were talking about cancer, we wouldn't expect someone to have cancer written their as their diagnosis without knowing what type of cancer they had. So I think, we have to be more confident in pushing back and asking the questions, and actually saying, if it's possible, we need a subtype, because if you've got frontal temporal dementia, that's going to look very different to if you've got Alzheimer's disease, and your needs are going to be very, very different. So I think it's really, really important that we really advocate for those people living with the condition, and actually just get more, ballsy, dare I say, in asking the question, whether we be
Yeah,
professionals or people who are
absolutely.
experiencing it ourselves, and going, well, I want to know. I want to know.
You're not the only person saying that. I know, for example, the Lewy Body Society talk a lot about the fact they feel this is a very underdiagnosed condition, that they believe
Mm,
many more people are living with Lewy body dementia than actually, are currently being diagnosed, and it really feeds into that subtype sort of diagnosis conversation. And then the other thing I wanted to pick up on, because we've got loads of questions in the chat, so I need to be quiet and get to those, was just this huge challenge when trying getting a diagnosis when you're younger is huge, isn't it? It's
yeah.
even harder than for an older person for many people.
It's hugely troublesome because, again, I think there's still this lack of understanding in health professionals that, there are this, 70,000 people living with young onset dementia is a significant amount of people. So it's not usual, but it's not as unusual as we would think it. And of course, I suspect there are many people who are living with young onset dementia who don't have that proper diagnosis yet. So I think because it's often attributed to anxiety, depression, changes in relationships, menopause, lots of changes that happen sort of in that midlife period. it's often the last thing that's on people's lists, and often the services that look after younger people are very different to the services that look after those who are older. So I think we've still got a lot of work to do in that space, and I know we've got some amazing people living with dementia who are younger, who are really vocal about this. And I think actually, again, that helps because people can start to see that it's not just a condition of older age, and that they should push if they think there's a problem that there's not being addressed. So I think, yeah, it's a very, very difficult and often very, very challenging journey for people who are younger, certainly.
Absolutely. And I think I personally I would suggest to have a look at the resources from Young Dementia Network.
Mm,
They do have some good information to help GPs, etc. And they really do sort of deep dive into some of that sort of assessment type challenges that younger people are facing. Right, let me get to the chat, Zena, because there's absolutely loads. Some of them are statements and some of them are questions. So I'm going to go through a bit of a selection of them. So Cindy says she's witnessed some GPs just make a diagnosis, no assessment, just a conversation. Um, Somebody asking about the slides, and I have replied about that, and they will go onto YouTube. And Zena's email address is also in the chat. She is happy to have any questions from you afterwards. Lynn, who I know is living with dementia, because lovely Lynn was with us at UK Dementia Congress last year, she absolutely loved and supported your common myth slides. I make this point constantly in talks I give. So that was really, really important to her.
good to
We've had a
hear.
signpost in the chat, so do go back through and have a look from Melanie, who's signposting to the Alzheimer's Society Dementia Symptoms Checklist, which is a very useful document that can help you
Definitely.
before you visit the GP. Um, going down. Lots of interest in delirium as well. So I've shared our link to our delirium webinar that we did. Kim says, earlier today I had to support a carer who is puzzled by a diagnosis for their parent of unspecified dementia. Would you advise the
Mm.
carer and or person living with dementia to query this with the consultant if they wanted clarification? And as an additional note, she's added, also the person had not had a scan.
So it's a challenging one. So sometimes scans are not conducted, and there's lots of reasons why. And sometimes that's because it might seem that that's going to be incredibly stressful for the person, or it's going to be very difficult because of physical issues. But I think again, if you're not clear, go back and actually ask why a scan wasn't offered. If it's not been made clear as to why a scan wasn't offered, in certain services there may, but I think particularly for an unspecified, there are some screening that we can do, and that kind of historical corroborating evidence that will enable us to see quite clearly what type of dementia some might have. And there might be a discussion about whether that person wants a scan or not, or whether they want to use that. And I have to say, there are different scanning protocols across the country. In some areas, you might get everybody is referred for a scan. In other areas, it might be very different because that might be about the resources that are available, who's doing the diagnosis. But certainly, if you're unsatisfied with that, I would go back and say, well, why is it unspecified? It may well be that they're saying that it's at a point where symptomatically there might not be any change in the way that that's supported. But I would still go back and ask those questions. If you don't feel that you've got the answers that you want, absolutely go back and ask those questions.
Super, thank you. So Abby's saying, I've just started in a role in primary care. Here we use coding. People are coded as senile dementia in XYZ, but also code with dementia late onset. I find it very confusing. And I think quite a few health professionals would possibly agree that coding can be quite confusing.
Absolutely. They're called the quality outcomes framework coding, and they change periodically. Now, I have to say they have got better over the years. They have become a little bit more subtype. So you get dementia with Alzheimer's late onset, those kind of things that come. You might see some very historical diagnosis as well. So things like senile dementia, that was
Yeah,
something that was
not
kind of
great, is it?
coded. No, that's an old one. But obviously, if someone's had a diagnosis quite some years ago, that would have been the coding. I agree, it's not helpful. What I would say is make sure that your practice is using the most relevant coding that's available for the quality outcomes framework. And actually, there's no reason why that can't be reviewed. In terms of, I think the term senile dementia is really derogatory, and I certainly wouldn't be advocating. But I think sometimes that happens because it's an older coding exercise. So yeah, again, there may be a bit of work to do in terms of raising awareness within the practice about the importance of the subtyping and appropriate coding and making sure that's as accurate as possible.
Brilliant, thank you. Another question: when is a post-diagnostic service no longer useful?
That's a really personal thing, I think, because it's, for some people, they may say, well, I've got my diagnosis, I've got as much information as I need at the moment, and I just want to get on and live my life, and I'll come back to you if I need anything. For others, they may just feel it doesn't meet their needs anymore. It's a really personal thing. I think one of the challenges we have is there's not enough of it about. I think we'd all agree that we need more post-diagnostic support and we need it much more readily available at a time that's really accessible and easy for us to get hold of. But I think, to be quite frank, it will depend very much on an individual's needs, and it may well be that actually they don't need information about the diagnosis anymore, or it may be more generalist advice they need about living well, that's not associated just solely with the diagnosis. So it's a very personal thing.
Super, thank you very much, Zena. Right. Okay, so let me go back up to some more questions. So, I'm a mental health social worker in the NHS in an older people's specialist team, and finding that many clients are given a dementia diagnosis through having UTIs, and I often have to
Mm.
query this as their presentation later is not relevant once the UTI has been cleared up, but then the diagnosis, often via a hospital, so it's already on their notes. I therefore aim to visit and assess as well as to not presuming lack of capacity based on this diagnosis. And that's super important, isn't it? Because clearly people will
Hugely.
present very differently when they're poorly.
Which is why I always put that delirium slide in, is, if this happens suddenly, if there's a huge change very, very rapidly, that's not dementia. It may, well, the person may have dementia alongside that, and which might have not been diagnosed, but you shouldn't be diagnosing someone when they're acutely unwell. And a urinary tract infection is one of many causes of delirium. There are lots of causes, but it tends to be the one that people are more familiar with. But absolutely, I've seen that time and time again. I have to say, going back to my ballsy statement, if I don't think it's right, I'll go back and say I don't think it's right and I want a proper assessment done. And you can ask for second opinions. You can make sure that that person's had all the correct assessments. And I think, sadly, we don't always get it right. People are labeled, and that's why I always say about the labeling. I think a label is very different to a diagnosis. If someone's not had the appropriate screening and diagnostic processes, then they don't have a diagnosis. They've been given a label, and that's not what we want from this. We want people to get the right diagnosis for them at the right time.
But
So I
thank you.
feel your pain with that one.
Now Kelly may have left us because she needed to, but I will read this out for the purposes of the recording as well. So she's an integrated project manager currently working with partners to put together a waiting well day with an opportunity to have conversations about what matters to you and access to up to 30 support organisations as well as taster sessions of how moving, self-advocacy, etc., etc. That sounds really super. That sounds like lots of us need that because there
I
are some really long waits.
There are some huge long waits, and actually there's some amazing resources out there that will support families affected while they're waiting. I think sometimes we just don't know where they are and how to get to them, so pulling them together and having that information. So and that's why I said, if you work in health or social care, do find out what resources are there, because that toolkit that you could just pass on, it might just be an A4 sheet with different organizations, but it will save that person having to fight through the system and find them themselves. Really, really important that they have that available to them.
Super, thank you very much. I'm just replying to somebody else who's wanting some links sent to them. So lots of nice comments about how helpful the webinar's been, and I would totally agree. So Zena, thank you for that.
My
Lynn's
pleasure.
saying she's going to note your name, so you've obviously made a good impact with Lynn. This was one of the most balanced talks I've heard in a while, but I'd like to hear a little more about the cons of having a
Mm,
diagnosis. And I think, if anything, that is perhaps one for me to pursue with people living with dementia to talk about pros and cons from their
absolutely.
own perspective, actually, because there will be a real diverse view on that, I would imagine.
Sadly, I
Um,
think one of the cons is societal perception still. And I think once until we change how society behaves and supports people with dementia, I think we'll never eradicate all the cons. And I'm sure people living with dementia will have their own experiences of those things and the lack of support available in some areas. So it's postcode lottery, unfortunately. Some areas it's very good, others it's not so good. So we can't say it's good all the time.
Oh, no, and time is marching away from us. I'm going to hold on for a couple more minutes because there's still quite a bit in the chat. Amy is saying, thanks for a really interesting talk. I'll be thinking about disseminating this information to the care homes that I support. I think there is often a difficulty getting GPs to understand the importance of seeking a diagnosis, particularly in advanced dementia for people already living in a care home. And I think you would agree. So I'm not going to ask you to comment because I can see
100%.
you nodding
Yeah.
your head. Lots of people saying they're going to have to leave. Sam saying, any advice on Samantha? Any advice on how to find local support services when you cover a large area?
That's a really good question. I always go for, you might well be go for like the Alzheimer's Society, Dementia UK, Age UK, organisations like that at a national level who may know what their local provision is. And often, Age UK, I have to say, often keep a lot of records about lots of the other organisations that work in their localities for various things. So I think find just sort of bigger organisations or find out who's been commissioned in your local area because there's lots of other organisations that provide that dependent on where they are. So it may well be that they are able to kind of filter down and give you some information, but some of it's just picking up the phone, Google search, and being really curious. And you'd be amazed at some of the community groups you'll find that are not known to anyone. They're not commissioned. They're just doing an amazing job in the local village hall or something like that. And actually, they could be the real critical support network for those affected.
Yeah, so there's lots of brilliant local services. So do go and look at those. There's also
Absolutely.
families, dementia carers count and Tide as well together in Dementia
Absolutely.
Day, both of whom work nationally and did a webinar for us last year. So comments around a lot of diagnostics don't use scanning as part of the assessment process. Lynn, I totally agree with you. Involve more people with an actual diagnosis in service provision and staff training. And then I think we're going to have to get to our final question. So Di's saying, is the initial GP assistant really fit for purpose? We had a service user who was strongly displaying symptoms but passed the GP assessment. As the condition worsened, we wrote to her GP to get a referral to memory assessment clinic, where 9 months later she was diagnosed with Alzheimer's.
So it's a really, really difficult one. Some of it's about the caliber of the people that conduct it, because sometimes that can be a challenge. But equally, there are people who can pass these testings because of, they're very broad spectrum. They're the general population tools, and we're all very different. So some people are much more able to bypass the scoring. But what I would say is most memory assessment services don't just look at that cognitive screening. If you've got collateral history about changes in behaviour, capability, function, mood, all of those things, and the family carers are seeing those difference, there should be, a referral with that corroborating history, which is just as valuable as the screening. So it's
Super.
a part of the jigsaw and it's not the whole complete piece.
Yeah, fabulous. So we've got links in the chat and do have a look at them for the Young Dementia Network, for their resources from the lovely Rachel Thompson, who is our Lewy body dementia admiral nurse, who does a lot of work with us at Dementia Community as well. She's put some brilliant links in there to help people who are concerned about Lewy body dementia. Linda's put the Dementia 100 Pathway Assessment Tool. So there's lots of brilliant links that have been shared, as well as the ones that we've put in the chat today, and as well as the ones that Zena shared. So, Zena, thank you so much. We've overrun, but I think that is testimony to the fact this is just such an important subject, and there's lots of lovely messages in the chat. Thanking you so much, and thank you from us for sharing some
My
fantastic
pleasure.
information with us. Thank you. So let me move us on then to our next webinar. So it is Play to the Final Whistle. It is on Tuesday, the 26th of May. It's a very aptly timed topic with the forthcoming FIFA World Cup. So please do go and have a look at our webinars page on our website to find out more and to book your free ticket. You can also follow us on Eventbrite. You will have been on Eventbrite to get your ticket today. So you can follow us on Eventbrite to find our very latest webinars the minute they go live as well. But yes, have a look at our webinars page, have a look at our Eventbrite. We very much look forward to seeing you on another Dementia Community webinar soon. But until then, goodbye.